So I work with the unit in the HSE called the Quality Improvement Division, and my two colleagues are here, Marie Tighe and Jacqueline Grogan. We stole Jacqueline Grogan from the Disability Federation of Ireland, so we have her experience, and also we stole Marie from the acute hospital sector, so we've got a good balance in terms of service and advocacy in terms of the work. Now, just bear with me. So I'm going to talk about the programme of work that we've been doing for the last couple of years in terms of preparedness. So some of the panel had already referred to some of the things that I'm going to talk about. And what we've done is we've been speaking to staff. It's predominantly staff because that's the work. I suppose that's where we're coming from. To find out, we're supposed to tell them that the Act is coming, and also to find out, well, what do you think? What's it going to mean for practice? What are your concerns? What do we need to know when we're writing codes and guidance and training? What do we need to know in terms of the reality of your day-to-day practice? So I suppose the slide here kind of represents that we have a long way to go, and that you cannot underestimate the breadth and the I suppose the difficulties that are going to be in terms of implementing this. So in terms of now, and some people kind of referred to this earlier on, what's happening? So we do have a national consent policy. In all of the sessions we do, we always say, hands up who's heard of it, hands up who's familiar with it. And it's actually quite scary in a lot of the sessions, and we cover the whole country, all different settings, a range of different staff. The numbers of people that are familiar with the national consent policy is abysmal. And I suppose that's a really serious concern to the operation of this Act in the first place. So I've highlighted a couple of things, and I'm going to kind of directly then talk about it. So we're very clear in the National Consent Policy, which was written, predated this Act. No other person, such as a family member, friend or carer, or no organisation can give or refuse consent to a health and social care service on behalf of an adult service user who lacks capacity to consent. However, it may be helpful to include and involve those who have a close personal relationship. Their role is not to make the final decision. So that's, I suppose, a starting point. And we also have that reinforced in the Guide to Professional Conduct and Ethics for Registered Medical Practitioners. It usefully talks about when there is no legal authority to make decisions, what to do and what to do. And we're not always talking about emergency situations. However, meanwhile, back at the ranch, we know that this concept of next of kin is reinforced, is day-to-day practice across all of our services. We know that next of kin, some of us know that next of kin has no legal authority to consent or refuse treatment on behalf of another. However, I'm going to walk you through what we knew it anyway, but we've now got it from talking to over 5,500 people across the country who said, oh yeah, we do that, yeah. So, and that's going to be one of the single biggest issues for implementation of this Act. An organisation, Sage Advocacy, and Emer's here from Sage Advocacy, did a piece of work about 2 months ago on what's the role of next of kin. So you can see, I'll read it out just in case any of you don't have your expensive or cheap glasses with you. So what is it? So 70% said someone such as a close relative who I'd like contacted in an emergency. That's what it is. Good. Number one. The second one, then, over half of them said someone who can make healthcare decisions or consent to medical treatment if I'm unable to. That's a problem. That's a major problem. Next, over half, someone who can make personal decisions about me if I'm unable to. And then someone who can make a decision about life support treatment for me. So obviously, and then there's others that are further on down the line. And then this was an article then that supported that next of kin only means that person to be contacted in an event of emergency. So in terms of where we see this, and I can see people nodding their heads, people that work in services will know, yeah, we do that. But I suppose in the absence of the Act, that sometimes people say, well, what else are we going to do? So we know that there's a pervasive use of the term of next of kin on admission forms. I was in hospital 5 weeks ago and I saw it, and I was actually seeking it out to see, am I actually right? There it was, on admission, who's your next of kin? What's the purpose of that? Oh, they'll make decisions for you if you're not able to. On intake forms at various stages of preparation for an intervention on the consent to treatment. Some places have amended it and some haven't. On discharge, it's everywhere. There is some evidence that it's changing. So we found this is a recent form that has been changed. So you can see I confirm that I've explained to the patient, parent or her legal guardian. So that's progress, but we know that that's the exception rather than the rule. Consent to treatment, we know that next of kin consent and sign treatment, whether it's therapeutic, preventative, diagnostic, palliative or for another purpose. We know that next of kin sign consent forms, and we've been told by services otherwise the intervention won't be carried out. The clinician needs a signed consent form. They will take the consent off anybody, and some services have said we're not going to challenge that because this person has been on a waiting list for 3 years. We're not going to stop that particular intervention. And you won't find evidence of this written up anywhere because it's poor practice. I suppose that's the other thing that we were that's pretty evident. And I think this has an implication in terms of research as well. Next of kin signing DNAR orders. We know that in some nursing homes that next of kin are required to sign a DNAR order when the person is admitted. I personally know somebody who signed her mother's DNAR order who was in an acute hospital who had consent, who had capacity, and rang her daughter up and said, there's a DNAR order, can you explain what that is? So, and had to get a solicitor to get it removed. So these aren't isolated incidences. And this talks about, so that we also know that there's not necessarily a good understanding about DNAR, do not attempt resuscitation. It varies around the country. So there's a whole host of work to do that you're supposed to be doing that in consultation with the patient rather than for the patient. We know, and anybody here that works in disability services will know that the Hickock Contracts, the Hickock will look for a contract of care that's signed either by the person or by a family member. So that's actually in a regulation. So that in itself is reinforcing that concept of next of kin. And these are the two regulations that you can see that they are requiring that. So that's a major piece that has to change. We know that next of kin access health records and data, which obviously is a problem for GDPR, but it's a problem for the implementation of this Act. We know that information is disclosed to next of kin without the consent of the person. And the other thing I suppose to say is I'm not just talking about people who cannot consent to decisions. These are people who can consent that information is. So that our starting point is so poor in terms of practice that we've a lot of work to do. So the consequences of that is that there's a prevailing view that next of kin have decision-making rights, that our practices and procedures reinforce this every single hour of every single day. It's going to be very challenging for staff to address this without knowing, okay, will I be supported in this decision that I'm going to say, no, actually, you're not having that information because you don't have the right to have it. And it's also going to be, I think some people alluded to it earlier on, it's going to be very challenging for people who have always made these decisions and who've always been given this information. So and we've heard this. We did a session recently. Anya was with us with Family Carers Ireland, who have said, why should I become an intervener when I've been an intervener all my life? So that's going to be a challenge, and that's going to be quite difficult. Apologies for the Irish supporters. That's an England shirt. I didn't realise my good colleague Jacqueline pointed out I don't like soccer. So what we're advocating is that next of kin should change to emergency contact. We need to take that language out of it to support the Act. And there's a piece of work that a major piece of work that we need to start with. And also to support the Act as well, on our forms to have those with legal authority. So at least we're setting the ground pretty quickly. So then the other thing, another thing, not the other thing, there's a number of things, is the whole issue of informed consent. Somebody alluded to it earlier on in the panel. And this obviously is going to have an issue where a person needs further support. What are we like? Are we informing patients when we're about to do an intervention? So this is another example of a consent form, which I think is a very good one. It's not the best one, but it's certainly, and I can say for a fact, because I was a patient 5 weeks ago, this did not happen. Nobody went through this information with me. And I'll skip you down to H. I have had the opportunity to read and ask questions about the patient information booklet on anaesthesia where available. Mother of God. Anaesthesia is really serious. You'd think that that's standard practice, that you should be given that beforehand when, to know all of the side effects and not 2 minutes before you're going into a major procedure. And then couple with that then somebody who has difficulties making decisions or who has an intellectual disability or whatever it is. That's not acceptable. So I think these are things that we have to do now, and we can do now. We don't need to wait for commencement. And again, so we give people choices that are completely bamboozling. And that's for somebody with decision-making capacity. and who doesn't have an underlying condition that's really kind of interfering with their ability to make a decision. There was a study done, the National Patient Experience, which is done annually. It's just being done at the moment. You can see involvement in decisions. 36% said they were not involved enough in their decisions. 40% said they were not adequately informed about the side effects of medication to watch for when they went home. Add all of those other complexities on top. That's really worrying. So you can imagine then, how would that be for somebody that had Down syndrome? Would it be 100% that they weren't informed at all? So I think these are challenges. This was another survey that was done with people in terms of informed choice in relation to breastfeeding. And you can see, again, the reason I'm putting this in, if you add a person that has any kind of impairment onto this, that this obviously is going to have an effect. I suppose just in terms of the light with some of this, there is a number of initiatives that are happening in the HSE which will support this legislation. So, hello, my name is. Really simple concept, but it's really important. Like I think that will help people. I'm not going to go through the rest of these, but all of these are about bringing about cultural change. The difficulty is they're not all pervasive, they're isolated, and that's our challenge, that these have to become custom and practice everywhere. There's an issue about the existing capacity assessment tool. So most of people in this room will be familiar with the mini mental state exam and MOCA, and we know that people have already said they're really worried about letting go of those assessments because they're not familiar with this one. And how scientific is this one? This is wide open to subjectivity. So we know that there's going to be I suppose people will want to hold on to those assessments until they're familiar with the functional assessment. Some other challenges then, so the whole issue of unwise decision. It's not about, some of the things that people have been saying to us, it's not necessarily about the unwise decision. It's about, my oath says do no harm. This says don't do anything. So how does that work? And also, some of the things that people have said, so unlike the England and Wales and Northern Ireland Act, there's not kind of all pervasive protections. So what level of documentation do I need? How many people need to sign off an unwise decision? What would be considered reasonable in terms of outlining risks? What protections, this is a big one, am I covered? What protections are in place if the decision results in an adverse outcome? And we cannot underestimate people's worry about that. So people are saying, I'm just not going to let them make the decision because I don't want to be hung out to dry by Joe Duffy, because that could happen, or by the family who don't agree with it, and I've supported it. So I think that's a genuine risk or a genuine concern. I suppose the other thing is time-poor settings, and Jerry already talked about this, that the time it's going to take to support people to make these decisions cannot be underestimated. And people are saying, well, in an acute hospital setting, that's a challenge. The time to determine will and preference, that people will skip to the quickest option instead of working through those options. There are some settings that it might be easier. The whole thing of relying on a multidisciplinary team. So what happens where I think Marie Ty doesn't have decision-making capacity and Jacqueline does think, do we have functioning multidisciplinary teams? We know that depends on where you are. And we also know the whole issue of refusal of treatment, that is there a potential that people are actually going to follow that? Is your Advanced Healthcare Directive valid and applicable? Who says? So there's going to be, I think, there's going to be a generation that until people get comfortable with these new concepts. Are we ready for advanced healthcare directives? I think that's, a fundamental question. I think some people are, but I think some people aren't. And we're writing the codes of practice on advanced healthcare directives on behalf of the Minister for Health, and we've been doing some workshops on the whole issue of basic care versus treatment. That has caused an absolute consternation about hang on, what do you mean you can't treat the person when they're in great pain? Of course you can treat them. Of course you can override. So I think that's going to be a huge issue. So if I say I don't want opioids at end of life or at any stage, but actually opioids are really good for you, they are going to relieve your pain. Having had opioids a few weeks ago, I don't want them. But, and I have an experience now that I never want them ever again. But, there's going to be that thing, can you trust a patient to make an informed decision? Do they really know about it? They're not a doctor or they're not a nurse. And I think that's a whole transition that we have to go through. Are we ready to say goodbye to best interest? I think it's interesting that in Northern Ireland that it's best interest, but it's not best interest. But here, I think we're going to have a big challenge of people actually that it's about that we're making the right decision for you rather than the other way around. I think it's going to take a while. There's a number of things that are going to be required. Home care packages to enable people to maintain their autonomy and independence. We know that on this side of the country there's no money for that, and there's no money for a lot of these things, but they're contingent on supporting this, like speech and language therapy, OT, neuropsychology, and plain English, etc. Okay, I'm being given the thing. So just in terms of what's required now, there's a number of things that are in the legislation that need to be clarified. Eleanor talked earlier about that only the court can decide when a person lacks capacity. But what does that mean for health then? Does that mean you can't? So take out emergency. What does that mean? So I need to do something. The person lacks capacity. Do I have to go to court? So if we think about the logic of that, does that mean that everything goes to court? And they're questions that we've been asking. We've asked the Department of Justice that we need to know. When can you? And having followed all of the rest of the Act, when can you go to court? In terms of what's needed now, greater awareness of the Act. We, like in social care, there's pretty good understanding. In hospitals, there's, I would say, zero understanding of it because they haven't heard about it. So there's a huge kind of challenge. So in terms of this, it's a poor old elephant that we're biting. But I think, the only way we're going to get our heads around it is just to segment it, to work out what are the pieces that, and also to kind of relate it to people's contexts. And the more we do work on this, the more we see all that under stuff, all that stuff is not about the Act, it's about what we're doing now. We have to challenge and we have to change so that there's a huge cultural change. For any of you that want information on, I haven't talked about the work that we're doing because we want to just reflect on this. If anyone wants to talk to us at the break, please do. My two colleagues are more than happy to chat to everybody. We also are happy if there's people here from the HSE or the wider health and social care services, we're happy to talk. We deliver sessions and we do kind of sessions all over the country, so we're happy to follow up afterwards. So thank you for your time.